It is my pleasure today to share our findings on the effect of blood-based biomarkers on cost and wait time in the diagnostic process for disease-modifying treatments for Alzheimer's disease. We have the expectation that a disease-modifying treatment will become available maybe as early as next March, but at the same time, our prior work has suggested that healthcare systems worldwide are ill-prepared to handle the expected caseload. The reason is that we have a large backlog of prevalent cases who have never been diagnosed and not enough dementia specialists to actually properly diagnose them. This means that we have to shift more of the triage to the primary care level because we cannot train specialists in a short time frame. We had done a review of potential tools to do that, and blood-based biomarkers came out as a potential solution. And we wanted to estimate their impact on the triage process formally with this model. So we use a Markov model that models the disease progression of the patient from cognitively normal over dementia to death, and a patient journey model that models the diagnostic pathway from the initial presentation at the primary care office to the final diagnosis for treatment eligible. We apply this model to the US population and project a time frame from 2020 to 2050. What we compare is two scenarios of what the primary care doc will do: mini-mental only or mini-mental followed by blood-based biomarker if that test is positive. And then we project wait times under each scenario. So if you compare the required number of specialist visits here on the y-axis over time here on the x-axis, you see here on the dashed line, that's the number of specialist visits that we have estimated to be available in the US per year. And if you look here at the blue line, that's the number of specialist visits that we would need if the referral will only be made based on a positive mini-mental test. So you can see that over all these years, the demand for specialists would greatly exceed the available supply. However, if you add the blood tests once the mini-mental is positive, you can see that demand drops pretty quickly under the expected supply. And that means for wait times that with a mini-mental test alone, the blue line, we will continue to see long wait times over the entire model horizon. However, once we add the blood-based tests, the wait time drops pretty quickly into negligible amounts of time. So what does this mean? For access to care, our findings suggest that a commercial blood test for the Alzheimer's pathology is going to help dramatically with access to a disease-modifying treatment. The key word to watch out for here is commercial, because we have assumed a blood test that runs on commercial equipment in a regular lab, so no particular rare skills required. The reason for this improvement is the large reduction of people that get referred to a specialist who turn out to have either no Alzheimer's or no cognitive decline. And so this combination of tests can nearly eliminate projected wait times entirely. At the same time, this also allows us to identify more patients for treatment because we have fewer patients waiting for their diagnoses, i.e. we can get patients treated in a timely fashion before they progress to a state in the disease where they will no longer respond to treatment. We also learned that the blood test should be used in mini-mental positive patients because the two tests have complementary information. The mini-mental tells us that somebody has suspected cognitive decline. The blood test tells us that the decline is due to Alzheimer's disease. And if we use only the blood test, we would refer people who are cognitively normal, even though they may have amyloid in their brains. So this amazing tool, this amazing technology is going to help us greatly in identifying the patients who can benefit from this potential breakthrough therapy. And I thank you very much for your attention.